Can you hear us online okay?
Yeah.
Yeah. Okay, great.
Yeah, thanks.
Okay, we're a couple of minutes past 5, so let's start. Thank you all for turning up in person. Great show. Sure, it's nothing to appreciate. But those online missing out on the free sandwiches and cans of Coke and Fanta. And
Champagne.
Champagne, VR and lobster and something. In the future, maybe we might even get some pizza from you, so keep an eye on them. But yeah, thank you for coming online in person. I'm delighted to welcome Francesco Giganti, a colleague of mine that I've worked with on several teaching and research projects. He's an associate professor of radiology at UCL, originally trained at San Rafael in Milan. And for those of you that are football fans like me, he's an AC Milan supporter. You can chat to him afterwards if you like about that. Originally came to UCL to do a fellowship, but liked it so much that he stayed doing a PhD and then has now been appointed in a permanent position. I think we first met at around a consensus meeting in around 2017 on use of MRI in the diagnostic pathway. And then I distinctly remember Vienna ECR 2018, East from the East, where half the UK contingent didn't make it to Vienna because they flew out on the Wednesday rather than Tuesday or how it worked. And Claire Allen, who works very closely with Francesco, couldn't make it. And it was between me and Francesco to give her talk on the fly. Francesco was a bit more junior at the time, was delighted that I was able to do it, having looked at the slides for about 15 minutes before the actual presentation. And I managed to get through that talk, but you would be eminently qualified to do that now. There wouldn't be any problem to give that. But 6 years ago, you're very grateful that I gave that rather than having to do it. But that's probably my first memory of us collaborating as well. But yeah, Francesco has his PhD was in around prostate imaging with MR, and in particular, these two topics he's going to talk on: image quality with Pi12, who's the kind of world expert on that scoring and assessing that, and the precise system which we use for follow-up scanning and active surveillance to see if there's change or not. And also, which I told him to leave off this talk, is another scoring system, PiFab, which is used in the setting of focal therapy to assess for treatment or recurrence. And that's something they do a lot of in UCL, is focal therapy for prostate cancer. It's a little bit less relevant to our practice, so I asked if we just concentrate on these two topics. But yes, Francesco, probably one of the most qualified people in the world to speak on these two topics. I'll hand over to Francesco. Thank you.
Thank you, Tristan. Good afternoon, everybody. I'm Francesco, as Tristan said. And first of all, I have to say that both scoring systems, PiQual and Precise, would have not been possible with all the work that Tristan and his group have done on this. So it's a personal thank you to you guys. Okay, so starting from the first scoring system. So these are the two aims of this presentation: to understand the importance of image quality in the PiQual score, and then to understand the importance of prostate MRI during active surveillance and the Precise score. So starting with the PiQual score, basically image quality of prostate MRI. The first differentiation that we have to make is between quality assurance and quality control. So when we talk about quality assurance, we mean for prostate MRI that we want to ensure that the quality of our scan is good. And this, for example, means that we have to meet the PIRATS guidelines and the technical recommendations outlined by the PIRATS guidelines. For quality control, we want to verify whether these quality standards are met. So the use of prostate MRI is increasing. As you all know, basically, both the EAU and the AUA guidelines now are supporting the use of prostate MRI. And we know that the prostate MRI is very embedded in the diagnostic pathway. And this means that we will have a high demand for high quality scans. And the number of scans will increase. But we also know that quality, as you can see from the second point, varies between centers and scanners. And this means that if you have a poor image quality, you will have a greater uncertainty and a lower accuracy in detecting clinically prostate cancer. So this is the reason why it is really important to perform prostate MRI and report it at a higher standard. Of course, it's not only about us as radiologists, but it's also about other aspects that can influence our quality. And for example, the way in which MR targeted biopsies are performed. So you can see here the three different methods: fusion, visual registration, the so-called cognitive, and then IMBO, which means MR guided. But it's also a matter of the number of calls, the experience of the operator, and the biopsy route. So these are basically the aspects that are not related to our job as a radiologist, unless we're doing targeted biopsies. I really like these two papers because they highlight the importance of having a structured and clear prostate MR unit in the hospitals. So the two papers are from the US and Canada. The first is from the US. And basically, they supported the creation of the so-called director of prostate imaging. The second paper basically assesses the improvement between a tertiary referral center and 4 peripheral institutions. And this is also supported by this paper here from the US again, where an academic institution reported more than 1,000 prostate MR per year partnered with a private institution. And they started basically a new prostate MR program in which the experts were teaching the local hospitals to read prostate MRI and to acquire it properly. And there was a significant improvement after the first 3 months. So the conclusion here was that academic institutions can help local centers to train radiologists, optimize the quality, and deliver high-quality interpretations. So if you have a look at prostate MRI, it's a love story of 40 years. And the reason I'm saying this is because the first study, as you can see from this graph, is from 1982. This was the first study on MRI of the human prostate. Starting from there, then we had some milestones. For example, the first study describing the prostate gland is from 1987. Then the first use of the endorectal coil from 1989. And after that, we have the first study using contrast in 1993. And quite recently, well, more than 20 years ago, but actually it's the last part of this journey, is the first study on diffusion weighted imaging, 2002. So here you can see a prostate MRI from 1987. So you can barely see the peripheral interstitial zone. This is supposed to be the bladder, and this is the rectum, right? We are lucky because nowadays, if we have a good quality MRI in 2024, we can have an image like this, which is much better. As you can see here, the peripheral zone, the transition zone, the urine in the bladder is clearly seen, and the rectum. But I can also tell you that if you don't have a good quality scanner nowadays, you can still have images like this. So we're very lucky because we have the PARADS document. PARADS version 2.1 guidelines, updated in 2019, as you can see here, tell us how to acquire good quality prostate MRI. And basically, they tell us the different parameters that we should apply for the 3 different sequences: T2, diffusion, and dynamic contrast enhanced sequences. They also outline the key points to achieve a good quality MRI in terms of the technique, the consideration from a clinical perspective, and the reporting of quality. In terms of the key imaging parameters, of course, as you know, we have different magnet strengths, 1.5 and 3 Tesla. We have the slice thickness that can be different fields of view, different B values for diffusion, and the temporal resolution for DCE sequences. So here you can see the technical requirements outlined in the PARADS document. The first thing I want to show is that basically there are some minimal technical requirements that are common for T2, diffusion, and dynamic contrast sequences. For example, the slice thickness that has to be 3 mm for T2 and DCE sequences, up to 4 mm with no gap for diffusion weighted imaging. The field of view can be slightly different between T2, diffusion, and DCE, and then the in-plane dimensions here. But then the other very important thing is this one. So basically the specific recommendations for each sequence. For example, it's really important for T2 weighted imaging to have an axial plane, and in addition to this, also a sagittal or coronal plane. For diffusion weighted imaging, it's really important to have a dedicated high B-value sequence that can be also synthesized. And the ADC map must be built up to using the B-values up to 1000. And for the DCE sequences, the temporal resolution must be up to 15 seconds, and a fast suppression or subtraction is strongly recommended. So this is a study from this center, from Tristan's group, basically, that looked at the scanner age. And basically what the graph is showing us is that the mean overall image quality of T2 weighted imaging decreases with the age of the scanner. So the conclusion was that actually using a cutoff of 7 years, we have a lower quality imaging. Of course, we also have to say that you can also have an older scan, more than 7 years, that can be well optimized, and you can still have good quality images. But this is the only study at present that is looking at this, which is really, I think, interesting. Then there is this review article that we carried out a few years ago. Basically, we did a review of the papers evaluating the topic of image quality in prostate MRI, and we found out that there is a lot of heterogeneity in terms of the cohorts, and also a lot of difference in terms of the scoring systems used to evaluate image quality. Mostly of the score, the majority of the scoring system is based on the 1 to 5 scale, but there was no standardized scoring system. The conclusion of this review was that MRI quality must be high both at the center level, so it's up to us to have up-to-date MR scanners, for example, and be experts, but also at the patient level, so we have to prepare our patients in order to minimize the artifacts. We did some preliminary work at UCL, and we basically assessed the quality and the sequence parameters in different centers in our network. And basically in 14 different hospitals with 23 MR scanners. We had a dedicated MR physicist and 2 radiologists that looked at the scans and improved the quality if needed. Here you can see the pre-optimization results. You can see that only 50%, for example, of the scanners had a good quality high B-value diffusion weighted imaging, and only up to 60% had good quality DCE sequences. Post-optimization, you can see that this number increased a lot. So from 50% to 74%, and from 59% to 88%. According to the PIRAS guidelines, it's also really important to have the optimal timing after biopsy when we scan our patients. And this is the reason why they suggest to wait at least 6 weeks, but even longer, in my experience, before scanning a patient who has had a biopsy. This is the reason why it's really important to have pre-contrast T1 weighted imaging to rule out the presence of artifacts like in here, for example, in the right peripheral zone. In terms of patient preparation, of course, we can use antispasmodic agents. We can ask the patients to evacuate and also to refrain from ejaculation. But the most important thing now for us as radiologists is to report MRI quality. And the first important paper that we have in this regard is this consensus meeting that was held in 2020. And basically 44 experts in prostate MRI had answered 2 rounds of a questionnaire with 55 questions. And among these questions, there was a topic of image quality for prostate MRI. And here you can see the results. So the first one is that we should always report image quality in our MR scans. But also we should always check our performance using histopathology as a reference standard. In terms of reader experience, we should always meet the technical requirements as per PIRAS document. And also we should always participate in MDTs. So the key points from this consensus meeting were that there is, of course, a learning curve for us. If we are experts, we decrease the rate of unnecessary biopsies, and we also know that contrast benefits less experienced readers. And of course, it's really important to attend MDTs. So after all of these review of the literature and these papers, we decided at UCL to come up with a scoring system called the PIQUAL. And here you can see the original publication from 2020. We created this scoring system from the Precision trial that I think the majority of you know. And basically, we will have a look now at PIQUAL version 1. So basically, the scoring system is a 1 to 5 scale that look at the 3 different sequences and basically check if the technical parameters, for example, for T2 diffusion and DCE sequences, meet the PIRAS document that I showed at the beginning. But also there is a more subjective aspect, which is the visual assessment. For example, for T2 weighted imaging, we look at some anatomical structures like the capsule, the seminal vesicles, or the ejaculatory ducts. For the diffusion weight imaging, we look at the quality of the ADC map, and for the DCE sequences, some anatomical structures like the capsular vessels or the vessels in the Arthrox canal. And of course, for all of the sequences, we look at the absence of artifacts. As I said before, PyQual is a 1 to 5 scale. And if we have a PyQual score of 1 or 2, we have a clinical implication. That means that it is not possible to rule in or rule out all significant lesions. For a PyQual score of 3, we have at least 2 MR sequences among T2 diffusion and DCA sequences that taken together are of acceptable diagnostic quality. So it is possible to rule in, but not to rule out all significant lesions. For 4 and 5 means that the quality is good. And we have 2 or more MR sequences independently of optimal diagnostic quality. With a PyQual score of 5, all MR sequences are great, and we have optimal diagnostic quality. And in this way, we will be able to rule in and rule out all significant lesions. I'm saying here that PyQual will undergo further refinements, but actually you will see this refinement very soon. There is also a educational review that is open access in Insights into Imaging, where we explain step by step how to apply PyQual. So for example, if we look at the different parameters, in terms of axial, sagittal, and coronal plane, here you can see an example of a good quality axial, coronal, and sagittal acquisition for T2 weighted imaging. So this is how it should be. For the adequate field of view, here you can see comparison between the adequate field of view here, which meets the Paris guidelines, and here is a very large field of view and the prostate is barely visible. For the adequate in-plane resolution, you can see here the adequate in-plane resolution on the right and the inadequate in-plane resolution, and you can see the images are not good. You cannot see clearly, for example, the pseudocapsule or the differentiation between the TZ and the PZ. And then there's less thickness, which is really important. And we have to remember that it must be 3 millimeters with no gap for T2 weighted imaging. Another very important aspect is the position of the Z-axis. And when we say that, basically, we highlight the importance of acquiring it correctly. And this can be done in 3 different ways. The first one is to have your Z-axis, as you can see from image A, perpendicular to the MR table in the patient, which I personally prefer. But we can also have the Z-axis orthogonal to the rectum in B here, and the posterior aspect of the prostate, or finally orthogonal to the long axis of the prostate. These are the 3 methods to put your Z-axis. And this is the more subjective aspect, the visual assessment. So basically, this is where the radiologist kicks in. We have to, for example, look if the pseudocapsule is clearly delineated, as you can see here, the hypointense black stripe here, or if the neurovascular bundles are clearly delineated here. In terms of anatomical structures, also, for example, the seminal vesicles, the right and the left, in this way, are clearly distended and visualized. This is a very good quality image where you can see the ejaculatory ducts, left and right. So if you see them, this means that the quality of your axial T2 weight imaging is very good. And this is very important, for example, for focal therapy, the sphincter, the external urethral sphincter that we usually evaluate on the coronal acquisition, as these 2 hypointense stripes here. So if you can see it very clearly, then this means that the quality of your coronal acquisition is very good. And as I said before, we also want to be sure that there are no artifacts in our scans. So in this case, you can see an example of motion artifacts. And here you can see an example of artifacts from metallic implant in the right hip. Then we have diffusion weight imaging. We know that the B-value is a factor that reflects basically the strength and the timing of the gradients that we use. And we all know that we can also calculate the ADC. In terms of the requirements from the Paris document, we know that the diffusion weight imaging must match the axial T2 weighted imaging plane. There must be an adequate field of view, but also the in-plane resolution must be good. And here you can see an example of an inadequate high B-value sequence and ADC map. And here you can see an adequate high B-value sequence and ADC map. When I say adequate, this is adequate because you can clearly see the differentiation between the PZ and the TZ on the ADC map. The slice thickness here, as I said, is up to 4, not 3, like T2, 4, again, no gap. And it's really important to have multiple B values acquired and a high B value. Here you can see the different B values from 0 to 1000, and then the dedicated high B value sequence here, and the reconstructed ADC map. So the ADC map is created using from A to D, from 0 to 1000, and you use the E, the high B value sequence, only to see the lesion. In this case, the lesion is the left anterior horn, and this corresponds to the area of low signal on the ADC map. So don't forget to use 0 to 1000 just to create the ADC map, but then you will need the high B value sequence to clearly see the tumor, if present. Again, the subjective assessment is the adequacy of the ADC map. And in this case, there is an inadequate map here. You can see, you can barely see the PZ and the TZ here. And here you can see very good quality ADC map, peripheral zone and transition zone. And finally, no artifacts on diffusion weighted imaging. And here we can see some examples of severe artifacts from metallic implants that basically make your diffusion weighted imaging non-diagnostic, both on the high B value sequence and on the ADC map. And there you can see artifacts on rectal air. You can barely see basically the left hemming lane of the prostate here on the high B value sequence and on the ADC map. So we should avoid these artifacts. Finally, the third sequence is DCE. And again, apart from the axial plane matching T2 and the adequate field of view, we also have to have an adequate imprint resolution. And here you can see two images, one with inadequate and one with adequate imprint resolution, where we can clearly see the lesion in the right peripheral zone between 7 and 8 o'clock here. Slice thickness, again, like T2 with imaging, 3 mm, no gap. And one of the most important things is to have a pre-contrast T1 weighted imaging available and fat suppression / subtraction. And the reason is that we need this to rule out the presence of artifacts, for example, after biopsy. In this case, you can see the artifacts in the right anterior horn after biopsy. And this is really important because we don't want to think that this is tumor. And the artifact is clearly delineated and seen, especially when the fat suppression is applied. Temp resolution. So we created PyQual version 1 according to PyRes version 2, because the precision trial was run using PyRes version 2. But now we know that for PyRes version 2.1, the temp resolution has been set at 15 seconds and no more 10. And then the adequate observation rate. So here you can see basically the temp resolution, which is 30 seconds between each image. And of course, if we have a temp resolution of 30 seconds, basically we will not be able to see the early washing of the tumor if present. So this is what we should not do. And the visual assessment, the more subjective part, is, for example, to look at the presence of the capsular vessels. As you can clearly see here, the capsular vessels on the left, very clearly delineated, very good quality MRI, but also the pudendal artery in the Alcox canal. So if you can see these two anatomical structures, this means that your quality is very good. And again, we can have artifacts here. We can have artifact from the metallic implant in the right hip, basically non-diagnostic DCE sequences, but also artifacts here from ocean. So another paper from your group, which is very, very, very interesting because it shows the impact of image quality in terms of clinical decision making. You can see here, for example, that if we have a good quality MRI, PyQual 5, then we will have a higher number of negative calls. This means that the radiologist feels more confident in calling negative scans. Also, if the quality is high, you will reduce the number of your PyRes 3 lesions. And this is what we want. We want to reduce the number of PyRes 3 lesions that we call. And this also is reflecting in a number of lesions that are biopsied, higher quality, lower number of lesions biopsied, especially for PyRes 3 lesions. And also in terms of number of scans repeated, if you have a bad quality MRI, 1 and 2, the number is 80%. For PyQual 4 or 5, good quality is 4%. This is really striking. So in terms of teaching PyQual, I know that Tristan did this fellowship 2 years ago, I think now, and I did the year before. And basically, I collaborated with Claire Tempany and her group in Boston, and I taught her radiologists and urologists how to use PyQual. So there was a pre-teaching case review. Then on day 3, we had a lecture like this with some hands-on workshops, and then we tested we tested again the attendees on a different set of scans. Here you can see the background of the different attendees and the different scans from different vendors, magnets, and different PyQuartz scores. We asked them to fill out the teaching lesson form, and then we asked them to use the dedicated scoring sheet for PyQuartz. And what we saw, very interestingly, was that there was a significant improvement in the ROC curves before and after the teaching course. So there was a baseline 0.59 R under the ROC that jumped to 0.96 with a significant p-value. And this was also true for non-experienced and experienced radiologists. So if we basically divide into non-experienced and experienced, both of the cohorts saw an improvement in evaluating the quality of the images. PyQuartz has been validated in 5 different European tertiary referral centers. It has been shown that poor image quality for MRI is associated with underestimation of the stage of prostate cancer. We also evaluated quality for the PRIME study. That is an ongoing study. Actually, it's just finished. The data has been presented in Paris last month, AAU. Basically, it's a study comparing biparametric and multiparametric, and you're part of this. And basically, we evaluated the quality before and after a quality improvement project. We asked all the centers to send us their scans, and we evaluated the quality of the different sequences, and also we basically told them if there was room for improvement. Here you can see the 3 most important feedback that we gave for each sequence. For example, for T2, it was really important that they adjusted the image resolution. For diffusion weight imaging, many centers were not acquiring a high B-value sequence, and for DCE sequences, the majority of centers had a temporal resolution that was not compliant with the PIRAS document. Here you can see phase 1, basically when they submitted their scans, and phase 2 after our feedback. And you can clearly see that at the end, after phase 2, we had 98% of the scans with the PyQuartz 5 and only 2% of PyQuartz 4, starting from a range of PyQuartz 3, 4, and 5. So PyQuartz version 1 was the first step towards a good quality prostate MRI, and it has gained a lot of attention. And this has also been highlighted in this review led by Tristan, where we know that there are different steps in the MRI diagnostic pathway where image quality plays a very important role, because everything starts from here. If you don't have good quality images, then you basically you impair all of the downwards process. But also in this important review, again, led by Tristan, it has been shown the importance of common artifacts in prostate MRI, and actually that we have to minimize them. And here you can see the different artifacts and the more susceptible sequence. And here you can see some strategies to mitigate it. So I really think that this is a very important table that we all should look at in order to minimize the artifacts and improve our quality. So after these 2 reviews and PyQuartz version 1, we ended up with PyQuartz version 2. And I apologize for this screenshot, but these are just from the proofs that we received last week. And the paper will be out next week, hopefully. I asked the European Radiology the timing, they said next week. Basically, this is as you can see here, a joint collaboration between Europe and our colleagues in the US as well. We worked on this, or we have been working on this for 3 years, I think, and eventually we simplified PyQuartz version 1. When I say simplify, is because we have less things to look at the moment. As you can see here, we have 4 points for T2 weight imaging, 4 points for diffusion weight imaging, and then only 2 points for DCE sequences. As you can see here, we basically removed all the technical requirements that we put in version 1, and we have only some essential requirements. For T2 weight imaging, it's important to have a slash thickness of 3 mm, but we're not interested anymore in the field of view, for example. For diffusion, the slash thickness, the importance of having a high B-value sequence, and the ADC map up to 1000 to construct it. And for DCE, there's less thickness, of course, the temporal resolution, and the presence of fast saturation. This means that if you don't meet any of these requirements, then you can't score that sequence. It's a 0. So you must comply to these parameters in bold. And then you have 4 different parameters for axial and sagittal or coronal 42-weight imaging. For diffusion weight imaging, the high B-value sequence, and also the ADC map as well. I won't go into too much detail, but you can read it once it's out. And for DCE sequences, again, the presence or not of artifacts and the presence or not of some anatomical structures. But the most important thing now is that PyQual version 2 is no longer a 5-point scale, but it's a 3-point scale. So we have a PyQual score of 1, 2, and 3. And the second very important thing is that we can now apply PyQual version 2 both to biparametric and multiparametric MRI. Here you can see different combinations according to the scores that you can give using this spreadsheet that I've just shown you. Just to highlight that PyQual 1 means that it's inadequate, PyQual 2 is acceptable, and PyQual 3 is optimal. There are no more clinical implications in terms of ruling in and ruling out the presence of cancer, but we are just saying if we should repeat the scan or if our scan is of optimal diagnostic quality. The other important thing is here with multiparametric MRI, contrast. Of course, the role of contrast has been downplayed compared to PyQual version 1, but it's still very important to upgrade or downgrade a multiparametric MRI. This means that you can upgrade a PyQual 1 to a PyQual 2 only if both criteria from the scoring sheet are met. If you are doing contrast, but either only one criterion or no criteria from the scoring sheet are met, then your PyQual 3 becomes a 2. So one of the most important things here is that, and this is what we wanted to stress in the paper for PyQual version 2, is that if you are doing contrast, you must use the multiparametric MR approach. So you can't use the biparametric approach when you're using contrast. You have to take the risk and do it right. If you do it wrong, you can have a good quality biparametric MR, but this will become a PyQual 2 because your contrast is not good. This is the most important thing, because we want people to do it right. So these are some points for PyQual version 2. So the image quality is inadequate with PyQual 1. It's really important to say where and on which sequences the quality is not good. For PyQual 2, the quality is acceptable and there is no upgrade or downgrade by DCE sequences. For PyQual 3, quality is great, but remember that if you're doing contrast wrong, then this becomes a 2. Also, it's really important that the last point, then when your quality is inadequate, you should not give a PIRATS or Likert score. Especially, you should not give a PIRATS or Likert score of 3 when the quality is bad, because we need to repeat the scan. And here you can see the differences between PyQual version 1 and PyQual version 2. The biggest one is the 1 to 5 and the 1 to 3 scale, and the multiparametric and biparametric for PyQual version 2. And also that this is now PyQual version 2, an expanded international working group, not only done from researchers from the Precision trial. So you will see it online very soon. So in conclusion, in terms of quality, we should implement this for every step of our diagnostic pathway. So we have PyQual, as I said before, this is the first step. And if we don't do this right, then all of the other steps will be hampered. Interpretation is the PIRATS, of course, then a good biopsy plan. We have to have a good biopsy procedure and also correlate our findings with pathology. And these are the 3 key questions that we should always ask ourselves. If the quality of my scan is adequate, if my interpretation, if I have the skills, and if I'm doing it right, and if my biopsy procedure is okay. And for this, we have, as you know, the weekly MDT meetings. It's really important to look at the cancer detection rate of our PIRATS scores, especially the PIRATS 3 lesions. And again, the use of image quality and scoring systems like PyQual basically can help in the collaboration between urologists and radiologists. So having said that, I think I will move now to the active surveillance precise score, and then we can have some time for questions, if any. For the precise score and active surveillance, basically, I think the majority of you know that active surveillance is an alternative to active treatment, and the aim of active surveillance is to reduce overtreatment. But at the same time, we want to ensure curative treatment without losing the window of curability. And as you can see here, this is the difference between active surveillance and watchful waiting. So the intent of active surveillance is curative and the life expectancy is more than 10 years. So we have a protocol for active surveillance, meaning that our patients have regular clinical examinations, PSA testing, and prostate biopsy. And progression, of course, is defined using these clinical or pathological thresholds. One of the biggest problems is that there are several different active surveillance protocols across the world. And there are also different selection criteria. And we usually use active surveillance, of course, for low risk and intermediate risk prostate cancer. And here you can see the definitions. But as I said before, there is variation between studies and between policies. For example, it's really different the way in which we scan patients, the frequency of imaging, also the frequency of repeat biopsies over time. And here in this table, you can see the different countries, for example, the US, Europe, UK, with the different organizations and the guidelines that they have for active surveillance. But the important table following this is this one, where basically you can see from the different bodies from America, Europe, UK, that the risk categories sometimes are different. The clinical stages including for active surveillance are different, and also the PSA values and the Gleason scores. What is really reassuring is that all of these protocols have very good outcomes, as you can see from the overall survival, nearly 100% at 10 years, which is really important. But again, there is a difference in terms of inclusion criteria. So our cohorts on active surveillance will be different among centers. And more than 1/3 of patients are reclassified during follow-up. What do we know about the role of MRI during active surveillance? We know that MRI, as you can see here, is useful to detect clinical prostate cancer at initial assessment of patients considering active surveillance, but it is really important if we're using radiological tools like MRI to define radiological significance and progression. We are getting some data, robust data now on the use of MRI, but the follow-up strategy still relies mainly on clinical and biopsy assessment. So at the moment, we cannot use MRI as a standalone tool to trigger follow-up biopsy. This is really important. The EAU guidelines actually are saying that we should always do a prostate MRI before a confirmatory biopsy, and that we should repeat biopsy if there is evidence of PSA progression or radiological progression on MRI, but MRI cannot be used as a standalone tool. Some papers have been published, also consensus meetings, where they say that actually, for example, PSA changes are not powerful indicators, so we need MRI. And also there are some changes on follow-up that can prompt the biopsies. But again, this is a mix of different things, PSA, MRI, digital examination. So we have to use all the tools that we have. This is our experience from UCLH, our 5-year outcomes of MRI. And basically, we looked at 670 patients, and we defined the event as any prostate cancer treatment or to watchful waiting, 4+3 or higher, or any death. And I think the most important thing here in the Kaplan-Meier curves, let me see if I can, no, sorry, I'm not able to remove the camera from there. But anyway, so you can see 4 different Kaplan-Meier curves here, stratified by 3+3 and 3+4, visible and non-visible at baseline. And what is really important, if we look at this, is that 3+3 non-visible and 3+4 non-visible, so blue and gray, tend to progress less than the visible 3+3 and the 3+4. This means that if you have a visible lesion at baseline and you enter active surveillance, you are likely to progress more quickly than the non-visible disease. Some studies have shown the relationship between ADC and the radiological progression active surveillance, meaning that patients with radiological progression have a lower ADC. And also there are some nomograms, including MR features like the highest MR suspicion score or the total lesion volume on MRI. There is also the prior study that some of you may know. Basically, it's a very important international study looking at the role of active surveillance, and in this case of MRI. There is an arm, the red one, where they're using MRI at different time points, year 1, at the end of year 1, year 4, and year 7, and they're looking at the role of MRI. We have been using MRI at UCLH for more than 20 years now, especially for our patients active surveillance. And here in this waterfall plot, you can see that the median annual growth rate was nearly different, significant different between 3+3 and 3+4. So you can see the 3+4 in orange, the 3+3 in blue, and basically you can see that the tumor volume increases, especially for 3+4 disease. And this is a hot of the press from Tristan and Istok and the rest of the group. Basically, the role of biparametric MRI, because as you know, there is a huge appetite now for biparametric MRI, and they looked at the role of biparametric in reactive surveillance. First of all, very interesting table, the scenarios where a multiparametric approach is still favored in patient active surveillance. For example, if you have a higher risk of progression for a fast PSA, doubling time, for example. If you have a bad quality MR, for example, due to the presence of pelvic metal work that will hamper your diffusion weight imaging, for example, or if you have patient-related factors affecting image quality. But there are some advantages on using biparametric MRI during active surveillance. And here you can see them. For example, you avoid the reactions to gadolinium, you reduce the need for medical backup and cost savings. There are, of course, some disadvantages, like that you could have a high indeterminate call of PIRAS-3 lesions, and there is no safety net in case with reduced image quality. But again, this is really important because it shows the importance of training also radiologists. So if you have experienced radiologists and the good quality images, then you can use biparametric MRI for active surveillance. And now the precise recommendations. So basically the first publication was from 2016. And here you can see the basically panel who convened in Milan. And basically we looked at the definition of clinically significant change on MRI for prostate cancer. Precise is again 1 to 5 scale that goes from 1, where means that you have had a resolution of previous suspicious features on MRI, to 5 when you have a radiological stage progression. A precise score of 3 means that your MR is stable. Of course, you can use the precise score only from the second MR onwards. You have always to compare your current MR with the previous or with the baseline. So you can't use precise at baseline MRI. Here you can see some example. For example, precise 1 means that there is a previous enhancing area that no longer enhances. Precise 3, you have either no suspicious features or all lesions are stable in size and appearance. For a 5, you can have extraocular extension. For a precise score of 4, you have a lesion that becomes more visible or a new lesion. The precise version 1 publication provided the dedicated case report form where you can score up to 3 lesions here, and you can give the different volumes, single diameters, 2 diameters, 3 diameters, and the volume by planimetry or using the ellipsoid formula. And then here you can give your precise score, likelihood of change from 1 to 5, and then explain which parameter has changed. Here you can see the lesion in the left peripheral zone from 4 to 5 o'clock on the different sequences. And here you can see how to measure it planimetry, slice by slice, or using the 3 different diameters. So A, B, C, D, or EF. This is our pathway for melanoma surveillance prostate cancer. We always do multiparametric MRI. And basically, we have a baseline MR and then an MRI after 1 year. Then if you remember the data that I showed, the Kaplan-Meier curves, according to the presence or not of a visible lesion at baseline, then we have a different pathway. If we have a visible lesion at baseline, then we will have a third MRI after 2 years. If we do not have a visible lesion, then we have MR based on PSA changes and kinetics. We partnered with an American company called MIM to create a semi-automated tool to control the lesions and give a precise score. And we compared this with a normal standard viewer. And basically we saw that if you have a dedicated semi-automated software, you can decrease the number of, decrease basically the reporting time and active surveillance. And you can also generate a PDF like this with the baseline and follow-up scan and the comparison and the lesion location. And then I also collaborate with Valeria Panebianco in Rome with the Bracco Fellowship. And basically we analyze the reproducibility of precise version 1 in 80 patients, 40 from UCL and 40 from Sapienza. And we analyzed the scans blinded, and we gave a precise score. And we showed that expert radiologists achieved substantial reproducibility for the precise score. even when we merge as a precise 1, 2, 3, and 4 and 5, you can see the percent agreement and the kappa value are pretty high. We also looked at the role of diffusion with imaging and precise scores, and we calculated the ADC for the lesion, the non-cancerous tissues, and the urine in the bladder in order to normalize it. And what we found was that increasing the precise score, 2, 3, 4, 5 here, and then this is the ADC. Basically, if you have a higher precise score, you have a lower ADC. And this is valid not only for the normal ADC, so the lesion ADC, but also when it is normalized to the healthy tissue. We also looked, this is back to London, to analyze and look at the different calculations for the lesion size, the 4 different definitions, and we also gave a precise score. And what we saw that is that no matter how you define volume and lesion size, then there will always be a difference in terms of radiological stability or progression. So you can use the 4 different definitions. You will always see a difference between precise score 2 and 3 or 4 and 5. And again, this is clearly seen in this waterfall plot where precise 2 or 3 is orange and 4 and 5 is black. Precise has been applied in different cohorts, and here you can see the 6 studies that have used it, and you can see the 2 studies are from one from Cambridge and one from UCL. But again, as I said at the beginning, the main differences are in terms of inclusion criteria and follow-up imaging. But the conclusion for all of these studies is that if you have a stable MRI, precise 1 to 3, and stable PSA kinetics, you should avoid routine repeat biopsy. And this has also been shown in this systematic review, where there is a trend towards improved diagnostic using precise. And it is really important, as supported by the evidence in this meta-analysis, to optimize the MR quality and reporting. Here you can see, for example, a case where you have 2 mm prostate cancer with Gleason score of 3+3 in the right PZ, left anterior TZ. This is from the PROMISE study. So basically there is no targeted biopsy, 5 mm template biopsy, and there is only some tumor here in the right PZ, the left anterior TZ, and A to D is the baseline MR, and E is the histology. Here from F to H, you can see after 1 year, you can see that the area in the left peripheral zone has reduced. It's no longer visible on the high B-value sequence, and there is only some minor enhancement here, which is thought to be a capsular enhancement. And basically, this is a precise score of 1 because some suspicious features now are no longer present. Here you can see from A to C the baseline MR, showing only bilateral 1 mm Gleason 3+3, no visible lesion. After 1 year, we see a lesion here in the left peripheral zone, 4 o'clock, ADC map and DCE sequences, and this was called as a precise 4. There is a new lesion. And targeted biopsy revealed 4+3, and the patient was treated with HIFU. And finally, again, a lesion here visible at baseline from A to D in the left PZ, again from 4 to 5 o'clock, and we had a Gleason 3+4 on truss. After 2 years, we saw an increase in size and conspicuity of on all the sequences, and with also some capsular abutment here. This was called a precise 5 because of the also presence of capsular enhancement here. Targeted biopsy revealed 4+3, upgrade 4+4 on radical prostatectomy. What about this? So here we have a baseline Gleason 3+3, as you can see here with the left PZ, the lesion is here. And then we see that after 18 months, we have artifacts. So you can see that the area where the tumor is no longer, is not basically, you can assess it. So we are not able to give a precise score here because we don't know if the lesion is increasing in size or not. What we know is that after 36 months, the lesion has increased in size and conspicuity, and there is now extraprostatic extension showing 4+3. So this is a precise 5. This is really important and shows that actually you should always have good quality MR images. Otherwise, you won't be able to give a precise score. You can call this as a precise 3, but maybe this tumor had already progressed. And here we have a lesion baseline in the right anterior TZ, 3 mm Gleason 3+3. Then after 1 year, we see an increase in size and conspicuity. You can see that the conspicuity on the ADC map is larger, and basically this was called a precise 4. What happens after 3 years? The lesion is still there. I can't see much difference, a lot of difference compared to the previous one. It's a precise 3. So this means that it's a precise 3 if you compare your latest MR and the previous one. But it's a precise 4 if you compare this to your baseline scan. So it's always, always, always important to compare your current scan both with the previous one, but also with the baseline, because the precise score changes. And again, with the fellowship that I did in Boston, I also did another fellowship similar to this with our colleagues in Paris, and the same structure: pre-teaching course, 2 days, then hands-on and workshops, and then post-teaching case review. And again, we saw an improvement, significant improvement, the area under the curve from 0.6 to 0.77 before and after the workshop, and also stratified by beginner, intermediate, and advanced readers. So again, teaching courses on precise are helpful. These are some data published by this group in Cambridge. Basically, it's really interesting to see and reassuring as well that this aligns very well with what we have published as well from our cohort. So there is a trend of the use of precise scores. You can see from the Kaplan-Meier curves with the baseline lesion present and not present, so blue and red and green, sorry. And basically that the conclusion for this paper was that lesion size, Lacker score, and PSA density have a significant impact on the progression-free survival time, but also that precise scores 1 to 3 have a high negative predictive value, and 4 or 5 have a moderate PPV. And this is what we saw in our cohort, very similar, basically. Precise 1 or 2 is red, precise 3 is green, and precise 4 and 5 is blue. So there is a progression, also a radiological progression, but also an event. Basically, you can see the events here. And also, this is interesting to see that there is a relationship between the PSA density in our cohort, precise 1 and 2 and 3, and precise 4 and 5. So the higher the PSA density, and it is more likely that you have radiological progression and, of course, the event. And again, from this group, also using delta radiomics and precise scores to predict prostate cancer, it is possible to use both things between two image assessments, so precise and delta radiomics during active surveillance. But of course, there are some limitations, and these have been clearly outlined in some reviews, and this is one of those. Basically, for example, there is interscan variability, and then we are not able to measure quantitatively the degree of radiological change, but also, for example, there are no thresholds to assess tumor growth, which is really important, and we don't know which kind of measurement we should use. And this is the reason why, hot off the press, precise version 2. And again, Tristan here and I collaborated a lot on this, and basically it's a multi-center project, basically with different radiologists and urologists across the world, as you can see. And basically, this is the updated precise version 2 scoring system. And again, this is a 1 to 5 scale. So we asked if they thought that basically it should be a 1 to 3, but actually there was no consensus. So it's still 1 to 5. The difference is that the precise 3 stable MRI is now divided into visible 3V and non-visible 3 non-V. And this is based on the evidence that we have seen in the different papers that actually a non-visible disease is less likely to progress. But we also have a precise X, like for pirates. This means that it is not possible to provide a precise score if the quality is non-diagnostic. You remember the images that I showed before, between the first and the second? It wasn't possible to give a precise score. That should be a precise score of X now. We have an updated case report form where we can score now up to 4 lesions, give a Likert and a pirate score, a precise score, and then also include the Pikewall score here. So it's really important to assess the quality during active surveillance. Here you can see basically the summary of the key points in the paper for the precise consensus 2 meeting. Again, very important to evaluate the quality of the scan. Also, in terms of significant change, I think this is where the disagreement was the highest. Basically, we could only agree on a significant change in size of more than 50% in terms of volume increase. So this is why we need a lot of research now in order to define these thresholds more accurately. So in conclusion, we have seen that we can use precise because we can identify men who progress in a timely manner for precise 4 or 5, but for those who do not progress, 1 to 3, we can also avoid repeated biopsy. We have seen there is an increased number of studies on prostate MRI using precise, and I will never stop stressing the importance of good quality images, and now we need widespread application of precise version 2. And for this, we need to improve the uptake of MRI during active surveillance using Precise version 2 as a global effort. So we need to collaborate even more now. And also collaboration between urologists, because we need, when we receive our clinical history, a complete prostate cancer history, the PSA measurements and the previous imaging, and in return, we will be able to give them a good quality scan with the structural report, and also we will always compare with the previous imaging. Thank you.